Tonight, the hot topic of menopause. Why does this change of life affect women so differently, and how can we better cope with it? The doctors are on call now.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing.
Just your head.
Pull red handle to open bag.
Good evening. Menopause is a process that most mature women totally understand, and men are left completely out in the cold. Or is that true? I've heard it's advised that if you are a guy and you do have an idea what is going on in a woman's body during that time in her life, it's best just to be supportive and otherwise pretty quiet about it. I will endeavor to do that during this broadcast as our female experts address the condition of female menopause. But if this is the yin, then what about the male menopause, or the yang? I should be able to speak about that one, shouldn't I? The theory is that as a man ages, his main sexual hormone, testosterone, naturally decreases, and that this may explain in some later middle-aged men symptoms like tiredness, depression, and diminished sexual function. A quick answer for you men listening before we get back to the female of the opposite sex, as my dad used to say, is that if you are experiencing such symptoms, a significant exercise program will naturally raise your testosterone levels and help you with those symptoms. Of course, failing exercise, you can have your doctor check your testosterone levels, a simple blood test, and if it's low, replace it. Enough about the yang and us guys. Let's return to the yin, the more important topic of the day, menopause in a woman. I invite you to call in tonight, right now or sometime over the next 1 hour, with your questions about menopause. The phone number is 1-888-376-6225. Again, that number is 1-888-376-6225. To speak to this valuable and worthy topic, we have invited an OBGYN from the Avera Medical Group Brookings, Dr. Ellen Hopper, and a family physician from the Avera Medical Group McGreevy in Sioux Falls, Dr. Karen Heiling. Thank you both for joining us. So Karen, you're from the McGreevy Clinic in Sioux Falls, and you've been practicing there for
21 years.
So family physician.
Family practice.
And your practice is combination of everything and anything, or a lot of women issues, or
a majority of women issues, all age ranges from newborns to I think my oldest is not quite 100 yet, but
Yep.
and everything in between. But a lot of my patients have aged with me, are in the menopausal age range.
So you have had an experience with understanding how it's going on, and you've also gone through it, is
Correct.
what you're telling me.
Yes.
Okay. And you're from where originally?
I'm originally from Redwood Falls, Minnesota, and I went to the University of Minnesota to medical school and came to South Dakota for residency and met my husband here and stayed.
There you go. Well, we're glad you did. So Ellen, you're a new OBGYN in Brookings.
Yes.
And you have not had menopause yet. I'm just going to say that.
Not yet.
So, but an OBGYN, you trained where?
I trained at the University of Kansas in Wichita.
Are you originally from the South Dakota area?
Yes, I'm originally from Pierre. So I was born and raised in Pierre, went off to college, went to USD for medical school, and then down to Kansas for residency. So, and now I'm back home.
And you're back to Brookings, and we're glad to have you.
Thank you.
And I guess I'd ask the two of you, do you see this as a major problem in women's health? Do people suffer bad from that? Let's start with you, Ellen.
Yes, I mean, menopause is a natural occurrence in every woman's life, and so dealing with the population that I see, only women, everyone has this transition in life and everyone goes through it, and while symptoms can be different for every woman, the time frame for menopause can be different for every woman. I think it is a big issue for all women going through something like this, and it's nice to have a conversation so that women don't feel like they're out in the cold, out alone, dealing with these symptoms and issues.
Symptoms of menopause. Karen, your comment.
Yes, I totally agree. Some women, I kind of got a kick out of some of the comments. Some of the women that say, "Oh, I never had a hot flash; it's no big deal," and the ones that want to hit them because it's so interferes with their life so much. And it can range, and it can last longer in some people and shorter in other women. And
so it's extremely variable.
Extremely variable. That is what I found.
All right. Well, we're going to get back to that in just a minute. On Call visited with Annette Johnson, PharmD, to discuss the various medications that can be used to reduce the symptoms of menopause, including hormone replacement, holistic treatments and with the concerns that brings.
Most of the time when we think of symptoms of menopause, I'd have to say most people would think hot flashes. And so the medications that are usually used to treat that are hormone replacement therapy. At least traditionally it's been hormone replacement therapy and specifically estrogen of that. But more recently, within the last 10 years, there's become a lot more information about how that may not be the appropriate thing for everyone. So there are alternative medications that are out there too, some other prescription medications, as well as some people are also using alternative natural dietary supplement type products. Hormone replacement therapy, like I had said earlier, has basically fallen out of favor in the last 10 years or so, and that's because in 2002, the results of a huge study had come out. It's called the Women's Health Initiative study. When the results came out in 2002 from part of the study, it showed that hormone replacement therapy actually could be harmful to women if taken after menopause. And harmful in the regards of it could cause heart disease, it could cause blood clots, which we knew all along, but that was one of the risks. Also could cause breast cancer. And so that definitely decreased the use of hormone replacement therapy because of the study that had come out. Now it still does have benefits. Obviously it does help to relieve the hot flashes, and it's the most potent medication out there to help with that. It also is protective for bones, so it can help prevent osteoporosis and also to treat osteoporosis. Since hormone replacement fell out of favor, now they're looking more at other agents that could potentially be effective for hot flashes, and some of those are venlafaxine, which is known as Effexor, Paxil, which is Paxil brand name is paroxetine, and then also medications like clonidine, gabapentin can be used. And those medications are not quite as effective as estrogen is, but they found some mixed results and can be beneficial for some women. They do also have side effects with them, but for the most part are tolerated quite well. Especially, none of them carry the serious risks that would go along with estrogen therapy, especially taken long term. Looking more at the holistic, natural, alternative supplements that are out there, the things that you'll hear more about are things like black cohosh, soy. There's also phytoestrogens. Those also can be used. Those are the main ones that I think of. The thing to remember with the alternative ones, though, is that they're not regulated, and each product that you get might be different. Even from lot to lot, they may be different. But also, another thing to remember with those agents, specifically the soy and the black cohosh, is that they do have some extent of estrogen activity to them. So women who have a history of cancers that may have been linked to estrogen should certainly avoid those and not use those, because it increases the risk of cancers in those patients.
I invite you to call in tonight with your questions about menopause. I mean, guys, you can talk about male menopause. I mean, let's get this telephone ringing here. The phone number is 1-888-376-6225. Again, that number is 1-888-376-6225. And I have to say that we've got 3 young people, Sam McCurry, Shirley Zhang, and Nick French back there just waiting for your calls. So don't disappoint them. Let's get your calls. So our last interview was a very interesting one where she talked about a variety of things, and we can talk about estrogen and the risks that it carries. Maybe that should be the first thing that we talk about. Karen, there are risks that estrogen truly helps the symptoms of menopause.
Correct.
But what are the risks? I mean, and how big of a risk?
The absolute reasons not to put somebody on hormone replacement therapy would be a history of breast cancer, history of uterine or ovarian cancer, heart disease. If a woman knows she already has heart disease, has had heart attack, or any clotting disorders, has had a blood clot, or is a carrier for one of the factors causing blood clots, and liver disease.
And liver disease.
And liver disease. They should not use hormone replacement therapy.
Heart disease, liver disease, clotting disorders, cancer of the breast, cancer of the ovaries.
Mm-hmm. And uterus.
And uterus. So if you've had those problems, or there's a very strong family risk, you would not use estrogen.
I would not.
Now, there's these numbers, like in 26 in 10,000 with the hormonal replacement, and 19 in 10,000 without the hormonal replacement. Isn't that what the numbers are? Something like that.
Something like that, yeah.
It's not much of a difference.
Right. Mm-hmm. Right.
So the risk is really kind of blown out of proportion, don't you think?
It got very much blown out of proportion.
I had one person come to me, no family history for cancer, absolutely miserable, went on the estrogen, and she came down with breast cancer later. And she feels that it was her choice on the estrogen that did that. And of course, I feel somewhat responsible, but is it truly the cause and effect?
Well, I think the thing you have to remember too is that a lot of the studies were done with higher dose estrogen and progesterone hormone replacement and in older women. And now we're finding, if the average age of menopause is 51.5 in our country, putting women on hormone replacement closer to menopause when they're having their initial symptoms, number one, is better, and number two, using the lowest effective dose of estrogen and progesterone, or just estrogen, depending on whether they still have an intact uterus. Those are things to consider. So I think the lowest effective dose that you can use for the shortest amount of time can give a woman great relief, and she doesn't have the necessarily significant risk.
Now, estrogen versus progesterone, I mean, both of them are dwindling. What are the ones which of the two is the one that causes the symptoms, and can you replace progesterone without the estrogen? Or?
Yes, so if a woman still has her uterus, then the recommendations are to use estrogen and some form of progesterone. You don't want to use an unopposed estrogen or just estrogen in a woman with an intact uterus, because of the increased risk of stimulating the endometrium and
then let
causing
it build,
cancer.
build without releasing it. So.
Right.
So when they get the progesterone, they have their menstrual cycles back, right?
If you use a low dose of estrogen, though, a lot of the women won't get their periods back.
So what would be a low dose estrogen that has the progesterone, so it's safe if you have your uterus?
The studies originally were done with 0.625 milligrams of estrogen. They now have 0.45, 0.3, half the dose that they had back then.
And many of the transdermal patches are even 0.025. I mean, significantly less estrogen than the the oral pills
Right.
that they used in the studies.
And, and then the old progesterone that we used to use was made from pregnant mare's urine, Premarin, pregnant mare's urine. Are we still using Premarin? Sometimes.
Yes.
Yes.
Okay.
Premarin is still available, yeah.
Yeah, and it's not a bad thing. I mean, it's just made from pregnant mare's urine, and that's okay.
Yep. And it's an estrogen,
It's an
not
estrogen.
a progesterone. Yes.
And it's well processed and sterilized, so we're okay with that.
We're
But there
okay.
are replacements that are just as good as Premarin, right?
Right.
Yes.
So that's an interesting thing. And I had another question before. So the other issue that I have, so if you're going to do this, you want to go low dose and for a short period of time to reduce your risk.
By short period of time, it's 2 to 3 years.
Right.
A lot of women think short period of time, you're going to give them to a couple of months.
Right.
But it's really 2 to 3 years and then get them off. And if you can't, that's okay too. The goal is under 5 years.
I had a patient who was a smoker and has to be on the Premarin or the estrogen replacement. What about smoking and estrogen risk?
There is an increased risk of clotting, of DVTs, pulmonary embolisms.
Blood clots to the lung,
Right.
deep venous thrombosis of the legs.
Yeah.
So clots in your legs, clots that flip to your
Right.
lung, problems related to estrogen, particularly if you're
And
a
that-
smoker.
yes,
so I don't
that
even
risk
go
is
there. I
absolutely
say if you're
increased.
smoking, forget it. Don't do that. You have your choice. Smoking,
Well, and hot flashes can be worse if you're a smoker too. So
quit smoking.
quit smoking.
smoking.
Yeah.
You know, and people get mad at me, and I look at them and I say, look, you know, if you were a doctor, what would you be saying to you? You'd be saying this. It's my obligation.
Yes,
so I'm going to say it strong and hard. Quit smoking. Now, the other issue that I wanted to make sure is that she talked about other kinds. And a friend of mine came to me today and said, you know, there's alternatives that are natural. And she addressed some of that natural estrogens from plants and other ways, not taking chemicals. What's your take on that? She kind of poo-pooed it a little bit because she said it's variable and you don't know what the doses will be when you take these natural products.
I agree. So the bioidentical hormones that we hear so much about, the herbal supplements that we hear so much about, do affect the estrogen receptor, and women can have some effect from those. There's also about a 10 to 30% chance of a placebo effect just with anything that someone would take. The problem with those are that they're not FDA regulated like all of our other medications. We don't know what is in each compound, and even if you're getting the same supplement from the same store, the same brand, we have no way of knowing that the regulation of that supplement is exactly the same every time.
Reader's Digest, it's Consumers Report did a study and looked at the doses of these natural products, and they're highly variable because they don't have to be regulated. They don't have to be, so they're not going to spend the money to make sure that it's the right dose. So you may be getting a lot more than you think you are, or
and the
a
next
lot
month,
less.
a lot less.
Right.
And the other thing I wonder is, estrogen is an estrogen, right? It's the estrogen effect that carries with it a risk. So if you take a plant natural product, it's the estrogen.
Right.
And it'll give you relief. It's giving you estrogen. Why not give you the artificial estrogen that you know exactly the right dose, and you're getting the lowest dose, and you go with that level.
Right.
Am I wrong? I'm right.
You're right.
Right.
All right. So we have a question. Is there a relationship between menopause and depression?
Yes. Well, in some of the research they talk about, is it true depression? Because a lot of the women don't really feel blue. It is more of anxiety, irritability, snapping at your children. Sorry, kids. But, and a lot of it is anxiety. And as I said before, it's a little bit of the sandwich generation. You have to worry about your kids, you have to worry about your parents, and you have your own life that you're trying to live. So there's just a lot of pressures during that time also, and whether that is adding into variable hormones and causing you to be more irritable and crabby. And
there's a lot of demands, aren't there?
There are a lot of demands.
We're the sandwich. We're taking care of mom and dad, and we're taking care of the kids, and we're the ones responsible, and that's a huge thing. My personal take is that the antidepressants really work for anxiety better than anything, certainly better than the tranquilizers that cause depression and make your memory loss or lose your memory. And so I'm much in favor of using antidepressants in this group.
I use a lot of antidepressants in this group, too.
Have you, either one of you, read the recent data that showed that it looks like Alzheimer's disease might be reversed by, I mean, not proven yet, but might be reversed by the SSRIs?
I did not see that. Interesting.
Very encouraging, and it's rat studies and human studies and PET scans and microscopic data that is supported. We'll see what it shows. But I'm less reluctant, that's a double negative, to use it if we need it. So when men are irritable, and I see men going through this in their 40s and 50s, there's something's happening to them. Maybe they're the sandwich and the pressure and the anxiety or whatever, and they're angry. I use the SSRIs and it helps with anger.
Yep.
All right, caller from Brookings. What about women who have had uterus removed but have ovaries? What symptoms should they have or expect when they reach their 50s?
Their symptoms, other than the irregular periods and bleeding, are pretty much going to be the same. They're going to get the troubles with sleep, hot flashes, irritability. Joint aches is another symptom of menopause. Some balance loss can actually be one of the symptoms of menopause also.
So, I mean, that's the reason they left the ovaries in the first place. I mean, you go in, you remove the uterus because there's uterine cancer, there's extra bleeding, or whatever it is that you have a hysterectomy, a removal of the uterus. When you're past menopause, generally they take the ovaries, right? But before menopause, you leave the ovaries because you want to have them have their natural estrogen and let them go through this naturally, right?
Right.
Correct. And when you've had your uterus removed and you have your ovaries, you will still go through all of the natural feelings of menopause. With your uterus out, you don't have to worry about taking a progesterone with the estrogen replacement, if that's the treatment option that you should choose for your vasomotor, hot flashes, those sorts of symptoms. So
vasomotor meaning?
Hot flashes.
Flushy, your vascular system dilates and constricts and dilates and constricts.
When they take, one more comment, when they take the ovaries out in a younger woman, their menopausal symptoms will be much more severe than if they leave the ovaries. They can go through it much more gradually.
So that's the reason to leave the ovaries,
right? Yeah.
Even with the risk of cancer of the ovaries.
Yep.
Absolutely. I mean, bone health. Ovaries are producing your estrogen for bone health, cardiovascular health when you're young. So
you leave the ovaries if you can.
Yep.
A caller from Minnesota. What's the solution for hot flashes in men? Now, I'm not going to ask you, Ellen. I'm going to ask you, a family physician. You deal with men.
I don't know that I've ever gotten that question before. But I would probably, I tell a lot of women you can also control some of the environmental factors that will trigger hot flashes. Set the thermostat at a comfortable level in your home, not too hot, not too cold. The appropriate bedding in your bed, cotton sheets, not the down comforter, if you always like that. Layer your clothing a little bit. Hot drinks will tend to trigger hot flashes in some women. Alcoholic beverages will.
Worse than the hot flashes.
Ellen and I were talking a little bit. I just saw a lady back at the clinic that I think a year ago she was complaining about her hot flashes, and she told me that she likes to have a glass of wine and sit in her hot tub in the evenings. And that helps relax her, but she was having terrible hot flashes. This year she came back and told me she cut out her glass of wine and her hot tub, and she sleeps a lot better.
What do you get? I would make a comment, though. One thing is that there are other things that could be happening that might cause hot flashes. We should always be aware.
Right.
For example, pheochromocytoma is a rare thing of the high blood pressure, and that can give you hot flashes, sweating, palpitations, and headaches. Well, or you're going through menopause, or you've got a pheochromocytoma. It could be that your thyroid is out of whack, too. I think that when people are anemic, sometimes they can have these feelings. And the other is a low-grade fever. People can have a low-grade infection of some kind, and they'll have hot flashes. So I think men and women have to realize that it might be the time to see the doctor. And also, in general, I like to say exercise is one of the most important things to help.
Mhm.
And the other is that if you are a guy, check your testosterone level. If you're in your 40s or 50s and you're going through that, maybe you're low on testosterone. I'm not pushing that, but and when you get older, maybe in the 70s or 80s, maybe you don't even want to know what your testosterone is. We have a caller from Sioux Falls. Had a hysterectomy at 36. Now I'm 49 and I have no libido. What should I do? Ellen, what's a libido?
Libido is your sex drive. So, and that can diminish after surgical removal of the ovaries or with menopause. We see decreased libido. It can be due to drug interactions, so certain medications that people take can cause
certain blood pressure medicines, even the antidepressants.
Antidepressants can cause decrease in libido. So she said she had a hysterectomy. I presume they left her ovaries because she was 36. She may be going through some of the perimenopausal symptoms, and perhaps her libido is diminished now because of those sorts of menopausal issues.
Maybe she's not exercising enough. I would say that.
Yes. There could
maybe she's smoking.
Yeah,
could be smoking.
There could be some underlying depression or anxiety. I mean, certainly those things can contribute if you're feeling stressed.
Maybe there's anger issues with their partner, and that needs to be dealt with. I always do think about depression as a problem with libido, and when I think libido is the issue, I turn to the Effexor antidepressants or the bupropion, Wellbutrin, rather than the SSRI group.
Right.
So, I mean, libido is an issue, no question. Brookings caller in her 40s on birth control and has had weight gain and sweating. Could this be menopause? Weight gain and sweating in her 40s.
Weight gain and sweating is a sign of menopause, but a lot of times birth control pills mask the menopausal symptoms until they actually go off of them. A lot of times in your 40s, weight gain is just a matter of less exercise and eating more and enjoying life and having
a normal life.
A normal life.
Join the millions of people who struggle with this problem, and it may not have anything to do with anything.
Right. Or it may, again, I think we can't forget about the other things like thyroid disease, that could cause weight gain, unexplained weight gain. Certainly if we aren't exercising and aren't eating right, we can explain our weight gain that way. But for people who are doing those things and still have weight gain that's unexplained, they're feeling fatigued, there's a variety of symptoms that go along with thyroid disease, and I think you have to keep in mind there's other medical problems that could be happening at the same time.
Let's talk about the perimenopausal bleeding story. When a woman is approaching the time where they're going to have menopause, but just before they do, oftentimes they'll have increased bleeding. Explain that.
So usually the perimenopause starts with
peri meaning around menopause.
Around the time of menopause. Menstrual cycles get shorter in duration. Your flow and the time that you actually have your period can actually lengthen, and that's sort of the first thing we see with perimenopause. Then later on in the perimenopausal period, you start to skip cycles, so you may have a period 1 month and go for 2 to 3 months and not have a period.
And then a big one.
And then you have a massive bleed you may bleed for, some women will come in complaining of bleeding for 10 to 20 days with spotting in between, and then they'll start bleeding again.
Is that the lack of estrogen or the lack of progesterone, or what's that whole thing? There's an physiology there that I don't quite remember what it was.
Yes, it's so the abnormal bleeding is usually because of anovulatory bleeding. So the woman doesn't ovulate, she doesn't have that progesterone withdrawal, and the lining of the uterus just continues to build up from her estrogen, and then she sort of has this big bleed that's irregular, and the endometrium can be sort of disordered, and so one area may bleed and the other may not, and then the next week the other area may bleed, and so that's the reason for that sort of irregular bleeding most of the time. But anytime a woman is over 35 and has heavy bleeding or bleeding in between periods or this irregular bleeding, it is important to remember we need to rule out other causes like endometrial cancer, and so an endometrial biopsy would be warranted in that patient.
Yeah, so red flag,
Yeah.
worry about cancer. Karen.
Right. It's 1 year. If you go 1 year without a period, you're considered to have completed your menopausal period time frame there. Any bleeding after a year is considered to be abnormal and needs to be worked up.
Okay, so that's post-menopausal bleeding.
Then you move it, yes. Then you move it
Post
right
meaning
post-menopausal,
after.
Yeah.
Explain how important postmenopausal bleeding is. I mean, what a flag that is, what a red flag that is.
That really means that there's something going on in the uterus, because your ovaries, as I tell my patients, should have died and gone to heaven by then.
Okay.
and the hormones should be gone. So there's something inside that uterus that is either irritating it, or, the bad thing would be a cancer that has kind of stirred up some bleeding, and that's what needs to be investigated and checked out.
So the OBGYN teacher at Emory University who taught me, I can remember him saying this, and he said it, and he said it, and he said it, and that is postmenopausal bleeding means D and C, which means that you need to go in there and you need to dilate and you need to curette the lining of the uterus and make sure there's not cancer of the uterus. So bleeding after menopause, you go in and see your doctor.
Absolutely.
Take home message. Remember
And you don't,
that one.
but nowadays you don't always have to do a D&C.
Yeah.
You can do the endometrial biopsy in the office.
In the office, you don't have to go to surgery.
Right.
So,
Or in ultrasound, doing an ultrasound to look at the thickness of the lining of the uterus and the shape of the uterus and see if there's anything abnormal there.
So go in. It doesn't mean D&C now. It
Right.
means
Go in.
go in and get
Yes.
seen by somebody like you guys.
That's right.
Okay. During one of the first production meetings we had when we decided to do a program about menopause, the idea was presented that we should ask several women who are experiencing it now to sit down together and discuss how menopause has affected their lives. So here then is the on-call menopause focus group.
A hot flash is really weird in that you can be just going about your regular business. Let's say I'm sitting at my desk, I'm working on a letter to a prospect, and then suddenly, just like that, it's like somebody turned a heat lamp on you, and you're just flush with heat, and your forehead starts beating up with sweat. And I have a little fan at my desk that I turn on, and so I'll have the fan blowing at me. I'll take my blazer, and now I have to, when I get dressed these days, I can't wear sweaters anymore. I always wear something that's short sleeved with a blazer over it in case I need to take off my blazer because I get so hot. And then you cool down in a matter of, I don't know, maybe a minute or 2 minutes, and then I turn my fan off and put my blazer back on, and that goes on and off throughout the day.
I think I've probably had symptoms of menopause for a couple years. I am 52, and I have been a very warm-blooded personality my entire life. I haven't worn sweaters for probably 20 years. But now I kind of feel like I might be on the downhill slide of this menopause thing. My thermostat has actually gone down. I have a jacket and a scarf on today, which I can hardly ever do. I did experience hot flashes, but it didn't seem like they were as intense as what I was hearing from other people. I have a friend who used to have to get up during the night and change her pajamas because she would be she would be so wet from sweating. I never experienced that. I'd wake up and think, ooh, I should throw the covers off, but it was never that uncomfortable. And I'm not experiencing any of those now. So I'm kind of thinking, I'm hoping I'm on the downhill slide of it.
Mine is similar. I'm 59, and maybe for about 4 years have had symptoms, but mostly just the hot flashes, and I like the hot flashes. Because I like to be hot. So like when I wake up at night with a hot flash, I'm like, this feels great.
Life gave her lemons and she made lemonade. I'm usually able to just keep going. When it happens during the day, I'm fortunate enough that, it is brief. And in my line of work, I'm busy with the kids and at the clinic. I don't have to stop and strip down, but in the house, oh yeah, the layers come off.
you just hear research, shows that, estrogen helps or something else helps or this, and then you find out there's a study that it causes breast cancer, and then and I don't know what to believe anymore. So I didn't want to take anything, and my OBGYN said that if it's not impacting your life severely, then it's best to stay off any kind of hormone, treatments, I guess. So I'm managing.
I don't know if that has helped me feel better, but I do take a couple different vitamins. I take magnesium and vitamin B6 that I have read really does help you. And I'm hoping that maybe at the end of the year to quit taking those, but for the, 2 years ago when I was so miserable, I feel markedly better now. I might be just at the end of the entire cycle, but I don't know. I'm kind of thinking that those vitamins didn't hurt anything either, but there again, you hate to stay on them long term. Horrible bloating.
So is that better?
Much.
That would be horrible.
Much better. And I had never suffered from that when I was pregnant with our daughters. I've just never been that. I've never had that. And so that was really, really uncomfortable for me. And then I was also not necessarily having hot flashes, but having insomnia. I was having a hard time sleeping. And I have read that that can be a side effect of menopause also. And so, life is pretty tough if you're not getting the correct amount of sleep. And so between exercise and trying those vitamins for a couple years, I feel much, much better.
And I suppose the length of time that it lasts varies, just like when it starts varies from person to person. I'm 54, and I think it started about when I turned 50, 51, something like that. And the other day I was talking with a woman who was maybe 10 years older than I am, and she was, waving some paper, making a fan out of some paper and waving it because she was hot, and she said, "Oh, these hot flashes just, kill me." And I thought, gee, she's probably in her mid-60s. And I said, "Well, how long do hot flashes last?" And she said, "All your life." And I thought, oh no, I'm doomed. But I don't know that that's necessarily the case.
It varies person to person, and that is the scary part. I don't want to do this. And I try to take your attitude, Liz, of just, kind of going with it. But it's like an oven on the inside of you, and you're just so hot. You're so uncomfortable. I almost feel like it takes a little bit of energy. Like every hot flash just drains you a little bit more. I don't know. It isn't real fun.
Well, again, I want to thank Sam and Shirley and Nick for answering those questions and for helping us out. And so they presented a significant amount of responses. I mean, we had one of those young ladies talk about liking hot flashes. What's your thought on that?
I don't hear that response too often.
Nor do I,
Yeah.
But that's great. If you can learn to live with them, great.
That's right. And there was a B6 thing, and I'm sure that a lot of people take certain kinds of vitamins. What do you think about vitamins? Karen?
I guess I'm not a real big pusher of vitamins. I mean, I do tell them a multivitamin a day is fine. Mainly what I do is make sure they get enough calcium and vitamin D in their diet. The vitamin D on the bottles, it says 400 international units is what is needed. That is if you live in the southern tier states where there's a lot more sunshine. Around here, we need 1,000 to 2,000 international units. Most people are vitamin D depleted when I've been checking them here.
Yeah.
It's rare to have somebody.
Boy, I found that same thing.
Yep.
2,000 is what I say. It's not going to hurt you. No. The Institute of Medicine said you're safe under 4,000 or 5,000. And probably safe under 10,000. And of course they recommended 800 and maybe more, but right now they're being conservative, 800. Well, I'm saying 2,000. And I think that may help that young lady's symptoms. She might try vitamin D, but I don't think B6 has been shown to be helpful. Have you seen anything, either one of you?
I haven't.
I haven't seen anything for hot flashes. I've seen it for nausea, but not hot flashes.
And if you're pregnant, you need to have folic acid.
Oh, yeah, absolutely. So a prenatal vitamin,
for a pregnant
important if
person.
you're pregnant.
But not if you're not pregnant. What did you say about food and multiple vitamin?
Well, a lot of people think that if they take a multivitamin, they don't need to eat well because they can get everything that they need out of the multivitamin. And that's not true.
It's just not true. I mean,
just not true.
It's not the same thing.
Right.
The food is the source of. I love to say, you don't need a vitamin. You need to eat right. There you go.
Mm-hmm.
So if you were going to talk about the sandwich generation, let's talk a little bit more about the stresses of life this time of a person's life, men or women. You deal, Karen, with a lot of people who come in their 40s and 50s. How much stress is related to that? Or is it just because we're having menopausal symptoms? Let's talk about that.
Well, I do think that there's a lot of stress, and then adding hot flashes, not sleeping well, is going to cause more, irritability and stuff. But I do think that with parents and worrying about parents and their health and their situation, and then your own job and your family and your kids. I have one in college, and sometimes I prefer not to know what he's doing. But it's simple things like, his car broke down, he lost his glasses in a river, and dealing with things like that it just adds stress to a person's life and makes it difficult to. Ellen here will be looking at the stress of a baby.
Yeah.
So you're
not sleeping.
Yes. So is this pregnancy thing stressing you out a little bit?
I don't have time to be stressed. I just started a new job and got a new house, so.
So don't even worry about it. Just
that's right.
Roll on through.
Yeah, roll on through.
Osteoporosis is one of those issues that a lot of people. I think that when the company came out with Fosamax and the drug that hardened bones, then suddenly everybody was checking for osteoporosis. I mean, we didn't check before, but now that there was a drug, that it almost felt like the pharmaceutical industry pushed us into doing all of this osteoporosis testing. I'm thinking there's a place for it, but I don't know that we need to be as attentive to this issue as we are. Now, counter that.
Sometimes I do have a hard time. Where do you fit that in? At 50, and women hate to, you come in and it's like, oh, you need your colonoscopy. Did you get your mammogram? Have you had your cholesterol checked? And by the way, you now need to worry about osteoporosis. If there's family histories, I definitely recommend testing and checking then. And if not, and if they're regular exercisers and they're getting their calcium and their vitamin D in their diet, I probably don't push it nearly as much as other physicians do.
Yeah. Do you have an opinion on that?
Yeah, I mean, I think, the recommendation is to screen postmenopausal women with a DEXA scan if they have one risk factor. Well, one risk factor is just being Caucasian. So I think you have to, weigh the risks and benefits. I think look more into their history. Have they had a fracture? Do they have a family history? Those
Are they
sorts
smoking?
Of things. Exactly. Are they smoking?
Smoking is a big risk factor for osteoporosis. I've seen one study that looked at doing osteoporosis DEXA scanning versus backing up against the door and seeing if you can put your back to the door and your head to the door and your neck to the door, and if everything, you can touch those parts of your body against the door, then that's as good as a DEXA scan. You don't have it. If you can't, then you have it. So then the question is, okay, so you have osteoporosis, or you have some sign of osteoporosis, and you know for sure it's osteoporosis, not vitamin D deficiency, because you can hurt yourself by taking one of those drugs and being vitamin D deficient. I think the first thing you do is you check your vitamin D, make sure that your other metabolic factors are okay and your thyroid is okay. Then you can talk about Fosamax or one of the other bone strengthening drugs. There's a new bone strengthening drug on the market it's a biologic drug. Does either one of you know much about that medicine?
I don't know much about
Prolia?
it.
Yeah.
A little bit. It doesn't have nearly the amount of GI side effects. That is where I've used it a few times. I started using it most recently on a lady that had a bleeding ulcer who had been on Fosamax. Developed a bleeding ulcer, and it does not have the GI side effects. She does have significant osteoporosis and is at risk of fracturing. She's a very physically active lady, so I do worry about that and stuff. So that's where I've used it.
I think that there is a time and place for every one of those, but I do think that I'm a little bit more concerned about the Fosamax and the like, because after 5 years,
right,
then they're saying, well, you should stop it because now we're knowing that there's some microscopic fractures and we don't know how long you should be on it, and the reality is we don't know if it's safe or not. So I'm a real fan of vitamin D and a real fan of a regular exercise program.
Yep, weight-bearing exercises and calcium and vitamin D, I think, are the big.
And you know, I used to be an anti-calcium. For the last year, I've been an anti-calcium person, but recently I've been a little bit. I have to back off on that anti-calcium thing because there's some data on the recent study that talked about all these vitamins bad, but calcium might be positive. There's a caller from Carthage. Used to walk with Dr. Heiling's mom, and are there alternatives for estrogen replacement? She is concerned about osteoporosis. It's calcium constipating. So, Karen?
I wonder who
is
it
there
is.
good alternatives? What do you think about if they don't want to use estrogen, they really want to try an herbal? Do you recommend one of these alternatives? I know there are physicians who do.
I don't so much. If they're really miserable and they're not a good candidate for hormone replacement therapy, I mean, if I use, my first option is to use the hormone replacement therapy. But if they're not a candidate or they don't want to, and they've tried some of the environmental things, I do send them to one of the clinics to see if they can get some relief from that. But I don't necessarily use those.
What about estrogen vaginal cream?
Oh, I do estrogen vaginal cream. It's a topical, so it will only help with the dry vaginal area. A little bit of effect on the bladder. That'll help with.
Helps with the bladder.
With a little bit of that. But otherwise, it's not going to help with anything else.
Now, this is a guy's perspective question. Through all the reading that I've been doing this last couple of weeks, one particular writer, and it was a woman, said that the libido decreases somewhat, but it's very important to be active sexually, and that it's. And I thought, yes. So, and that is because you need to keep that whole system down there working, or if you don't use it, you'll lose it. I mean, you know, and then you won't have that particular thing. And also, there's that two things that work together when two people are connecting in one way, they connect in other ways as well. Comments?
Yeah, I agree. I think, you know, women have vaginal dryness or pain with intercourse after menopause, and so they just sort of completely stop their sexual activity, and that's not good either. There are, like Karen said, vaginal estrogens that can be used. They're topical, they're not systemic, so they don't have the increased risk of blood clots and stroke and things like that the hormone replacement therapies would have. Lubricants, things like that. I think it is important to keep up your
sexual activity. Lots of lubrication. Any comment about types of lubrication really quickly?
Water-based.
Water-based lubrication. Spearfish caller said ramifications for men using estrogen for prostate cancer, and the answer is they go through hot flashes, they have menopause symptoms, but it saves them from cancer, and it's only used when absolutely needed. Okay, well, it's time to hear this character give some essay about menopause, so let's hear what he has to say. When I was growing up, I remember laughing with my mom about the fact that she was going through menopause at the same time I was experiencing puberty. Double trouble, she said. My wife tells me, don't even imply you can understand menopause. The scientific literature defines menopause as that natural time in a woman's life, generally between 45 and 55 years of age, when ovaries stop producing eggs, estrogen and progesterone levels decrease, and menstruation stops. But this description doesn't do it justice. Although extremely variable, the symptoms from the hormonal changes happening during this phase in a woman's life are sometimes very uncomfortable. To better understand those symptoms, I asked a woman who has had breast cancer treatment, which works by turning off all the estrogen in her body. Although wonderfully effective in fighting cancer, the price for the cure is sudden and complete menopause. Horrible hot flashes like you're burning up inside and there's no relief, is how she put it. My emotions are very changeable, with anger spells to tearful to anxiety, and when you feel crappy, everything else is crappy. Headaches, urinary frequency, and dryness of the vagina all come along with it, but the hot flashes are the worst, she said. In contrast, most women have a more gradual decrease of estrogen, so symptoms can be less severe, but not always. A postmenopausal non-cancer friend told me, "It was like slamming into a brick wall at 90 miles an hour. When women say I have never had a hot flash, I say, good for you, but I hate you. They should use it as a torture device for male terrorists. He would buckle faster and would tell you anything because he hasn't been toughened by childbirth," she added. Lowest dose estrogen replacement is worth the small risk of cancer and blood clot, she said. It saved my marriage and my life. But that option is not available for our cancer patients. She described relief by getting enough good sleep with high-quality cotton sheets and a fan in the bedroom at night. Also, antidepressant medications encourages sleep, reduces anxiety, and even cuts the hot flashes a bit. And of course, exercise helps a lot, she added. I would never claim to understand what it's like to go through menopause. I'm just happy I don't have to go through it. So that's a great story. I wanted to make a point that it's Chris Ram's birthday, the executive director of the American College of Physicians for South Dakota, my partner in crime there, and it's her birthday, and she's the one who ran into the brick wall at 90 miles an hour. Sorry, Chris, I had to tell you. Thank you and happy birthday. So take-home message, Karen, we'll start with you.
I guess a couple of things. I think women can get through menopause doing some common sense things: exercise, quitting smoking if they can, see their doctor on a regular basis and get educated if they need to, maintain a relationship with their husband, whether it's, having to adjust the thermostat or having to adjust the bedding, or, talk to them about it. And I think that, hormone replacement therapy is an option down the road for a lot of women, and they don't need to be miserable.
Yeah. Great.
Ellen. Yeah, I think my take-home message would be similar. Hormone therapy is not all bad. I think you need to individualize your treatment with your physician. There are very good options for hormone therapy. I think the big key is low dose and, for 5 years or less, if possible, to treat your symptoms. And that's probably the biggest key. I think the other thing to keep in mind is that the bioidentical hormones and the herbal supplements, while they may work or have a placebo effect for some women, they aren't regulated, and so we don't know what's in them, and perhaps that's why a lot of physicians don't push those treatment options as much for women.
Right, and I guess I would say that those alternative hormonal therapies work because they have estrogen in it. It's the estrogen that makes it. So we want to thank you both very much, and I'd make a comment: make sure that relationship between the man and the woman stays good. You got to work together. So thanks so much. Yeah, 2 minutes. He says we've got 2 more minutes. Okay. Well, let's. I would ask you this issue of menopausal, the postmenopausal woman, quickly. I'm going to start with you about the 80-year-old woman. Any particular comments about an 80-year-old woman, feminine issues that we need to remember to talk about? In an 80-year-old woman, postmenopausal.
Well, some of the questions that I get from 80-year-old women: when do I quit doing pap smears? And 80, I'm fine. You don't need to do that anymore. But also when they are coming in, sometimes it's not as easy to take care of yourself. So sometimes it can be some personal hygiene issues that just need to be addressed a little bit with an 80-year-old woman. Some of the 80-year-old women are, in great shape. They're exercising. They're doing all the right things, and they are also the ones that don't look like they're 80.
They are, aren't they? I mean, I see these ladies who are 80, and you just can't believe it.
Right, and there are the ones that are not smoking, they are exercising, they're eating well, and they're taking care of themselves, and they're coming in for their regular checkups.
I think that walking program. You walked so you can keep on walking is important. Ellen, anything for the 80-year-old woman?
Yeah, I think something to keep in mind for the 80-year-old woman that's postmenopausal would be a lot of times we'll see women with recurrent UTIs or vaginal infections and things like that, and they think they have to live with those things. Pelvic organ prolapse, urinary incontinence, those, you know, whether you're 50 or 80, those are things that you don't have to live with. There are good treatments. And a lot of times all you may need for that is estrogen.
Well, it's great. Thank you so much for joining us, and stay healthy out there, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.